Hi, and welcome back to the Pro PA podcast. I'm Angie Urbina, your host for this cardiovascular series. Today we're covering a very common and impactful condition, hypertension. This so-called silent killer affects millions of adults worldwide and is a major risk factor for cardiovascular disease, stroke, and kidney failure. We'll break down the essentials, what causes hypertension, how it presents, how we diagnose it, and how to manage both chronic hypertension and urgent situations like hypertensive emergency and hypertensive urgency. If you're preparing for the PANCE, a practicing PA, or a medical enthusiast, this episode is just for you. Let's start off with the following definitions that were suggested by the American College of Cardiology and the American Heart Association. A normal blood pressure is considered a systolic of less than 120 millimeters of mercury and a diastolic of less than 80 millimeters of mercury. An elevated blood pressure is a systolic of 120 to 129 and a diastolic of less than 80 millimeters of mercury. Hypertension is broken down into stage 1 and stage 2. Stage 1 is a systolic of 130 to 139 or diastolic of 80 to 89. And stage 2 is systolic of at least 140 millimeters of mercury or a diastolic of at least 90 millimeters of mercury. Now let's talk some basic pathophysiology. Blood pressure is the force of blood exerted against artery walls and is controlled by cardiac output and systemic vascular resistance. When either of these increases, so does blood pressure. In primary or essential hypertension, which accounts for about 90% of cases, the exact cause isn't known, but it's linked to genetic, lifestyle, and environmental factors. Things like a high sodium diet, obesity, physical inactivity, and chronic stress. Then there's secondary hypertension, which is caused by an identifiable condition. Think of things like kidney disease, hyperaldosteronism, pheochromocytoma, or even certain medications like NSAIDs and oral contraceptives. Who does hypertension affect? It doesn't discriminate, but it is more common in certain groups. Older adults, Black patients, individuals with obesity, those with a high sodium diet, excessive alcohol consumption, and people with a family history of hypertension are at higher risk. We also need to be vigilant about secondary hypertension in patients under 30 or after age 50, or those with resistant hypertension, meaning they're on 3 or more medications but still hypertensive. As far as clinical presentation, most patients with hypertension have no symptoms, hence the term silent killer. But when symptoms do appear, they may include headaches, dizziness, epistaxis, or tinnitus. The clinical presentation of secondary hypertension may present with features specific to the underlying condition, like episodic headaches and sweating in pheochromocytoma. The diagnosis is made with repeated blood pressure readings. Use an average of at least 2 readings obtained on 2 different days and should be confirmed using out-of-office blood pressure measurement whenever possible. A single elevated blood pressure in the office doesn't make a diagnosis unless patient is presenting in hypertensive urgency or emergency, or a patient who presents with initial blood pressure above 160/100 who has known target end organ damage. A basic workup should include CBC and BMP, checking for anemia, kidney function, and electrolytes, a lipid panel, which is necessary to calculate cardiovascular risk and as a modifiable risk factor, fasting glucose to check for diabetes, an electrocardiogram to assess for left ventricular hypertrophy, which is a strain pattern often seen with hypertensive heart disease, serum uric acid, because hyperuricemia is a relative contraindication to diuretic therapy, a urinalysis to check for hematuria, proteinuria, and casts, and lastly, thyroid-stimulating hormone T3 and T4 to assess for thyroid function. Moving on to the management, this depends on the stage and presence of comorbidities. Lifestyle modifications are always the first step. A DASH diet, weight loss, exercise, smoking cessation, limiting alcohol consumption, and limiting caffeine can make a big impact. As far as pharmacologic therapy, some patients have a compelling indication for a specific drug or drugs that is unrelated to primary hypertension, such as using an ACE inhibitor or an ARB if patient has proteinuria chronic kidney disease. In addition, the choice or drug therapy is different in pregnant patients or patients planning to become pregnant. If there are no specific indications for a particular medication based upon comorbidities, most guidelines recommend that initial therapy be chosen among these four classes. They are considered the first-line medications, and they are thiazide diuretics, ACE inhibitors or ARBs, especially in diabetics or those with chronic kidney disease, and calcium channel blockers. For patients with resistant hypertension, consider evaluating for secondary causes. And it is important to note that the target blood pressure is based on patients' risk for having a future cardiovascular event. Now, let's talk about when hypertension becomes an acute problem. Hypertensive urgency is when blood pressure is severely elevated without target organ damage. This is a systolic blood pressure greater than or equal to 180 and or a diastolic greater than or equal to 120. These patients can be managed with oral medications and a close follow-up. Hypertensive emergency is when blood pressure is severely elevated with evidence of acute end organ damage. Things like a stroke, myocardial infarction, aortic dissection, or acute kidney injury. This can be life-threatening and require immediate treatment, usually with IV medications in a monitored setting. Now, here's a key difference between textbook medicine and real-world practice. Textbooks emphasize immediate intervention when blood pressure is elevated, but in reality, overtreating asymptomatic hypertension too quickly can be harmful. The goal isn't to normalize blood pressure overnight, but to bring it down gradually, especially in hypertensive emergencies. It is generally unwise to lower the blood pressure too quickly or too much, as ischemic damage can occur in vascular beds that have reset their autoregulatory threshold to the higher level of blood pressure. For those hypertensive emergencies, mean arterial pressure should be reduced by approximately 10 to 20% in the first hour and then gradually during the next 23 hours, so that the final pressure is reduced by approximately 25% compared with baseline. The major exceptions to modest and gradual blood pressure lowering over the first 24 hours are acute phase of ischemic stroke, acute aortic dissection, and spontaneous hemorrhagic stroke. Let's go over a few key pearls. Number 1. If a young patient has resistant hypertension and episodic headaches, consider pheochromocytoma. And number 2. In a hypertensive emergency, don't lower blood pressure too fast. Aim for 10 to 20% reduction in the first hour to avoid ischemic damage. All right, let's practice some questions. Question 1. A 52-year-old woman presents for a blood pressure follow-up. She has been following lifestyle modifications as recommended last visit and is currently asymptomatic. She brings a home blood pressure log that shows blood pressures consistently elevated over the last 2 months. Today, her blood pressure is 150/95. She has no history of diabetes or chronic kidney disease. Which of the following is the most appropriate initial treatment? Is it A, start a beta blocker, B, continue monitoring and follow up in 3 to 6 months, C, prescribe an ACE inhibitor or thiazide diuretic, or D, start combination therapy with 3 antihypertensives? I'll give you a couple of seconds. If you chose C, prescribe an ACE inhibitor or thiazide diuretic, you are correct. Stage 2 hypertension with persistent elevation despite lifestyle modifications warrants pharmacologic treatment. Beta blockers are not first line unless there's a specific indication. And just a reminder, stage 1 is a systolic of 130 to 139 or diastolic of 80 to 89, and stage 2 is systolic at least 140 or diastolic at least 90. Question 2. A 65-year-old man with a history of uncontrolled hypertension presents with acute confusion, headache, and blood pressure of 220 over 130 millimeters of mercury. Fundoscopic exam reveals papilledema. Which of the following is the most appropriate next step? Is it A, start oral labetalol and discharge with close outpatient follow-up? B, start IV antihypertensives and admit to the ICU? C, observe in the ER and repeat blood pressure in an hour? Or D, prescribe a short course of steroids? If you chose B, start IV antihypertensives and admit to the ICU, you are correct. This patient is in hypertensive emergency, with signs of end organ damage being neurologic symptoms and papilledema. IV antihypertensives with monitored blood pressure reduction are required. Great job! Hypertension is a cornerstone of primary care, and understanding how to manage it can significantly impact patient outcomes. Whether it is recognizing secondary hypertension, managing chronic cases, or handling hypertensive urgencies or emergencies, being proactive can save lives. Don't forget to subscribe and turn on notifications so you never miss an episode. And as always, this is the Pro PA Podcast, where future pros in medicine are made. See you next time.